Thank you so much. Um, so as David said, I'm going to be talking about TB treatment for drug-susceptible TB and TB treatment for people living with HIV. Now, having heard from David about how the TB bacterium works and from Tanya as to how drugs are developed, we're going to talk in this next 20 minutes about how the drugs are used together to treat TB and the advances in treatments that we have been having. So these are my disclosures. So we're going to quickly review the standard drug-sensitive TB treatment. We're going to look at the evidence for treatment shortening and simplification of treatment for drug-sensitive TB. We'll discuss the challenges of treating TB in people living with HIV, because TB still remains the leading cause of death globally for people living with HIV. So although most TB in the world is not in people living with HIV, it is the leading cause of death in people with HIV. So particularly important to find regimens that are appropriate and accessible and able to treat TB for people living with HIV. And then we'll talk about the evidence for shortening treatment and the evidence that dictates the timing of co-treatment of TB and HIV for people living with HIV. So very briefly, because this is probably quite familiar to most folks on the call, the standard drug-sensitive TB regimen is a 6-month regimen of daily treatment using 2 months of 4 drugs and followed by 4 months of 2 drugs. So isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months, followed by 4 months of 2 drugs, isoniazid and rifampin. And these drugs are used in combination to attack the TB bacterium at different stages of its life cycle, attack early bacterial growth, attack some of the persisters, as well as maintaining a length of treatment to ensure that all persistent bacteria are eradicated with the goal of TB cure with the standard course of treatment. And this is, as you can see, a lot of medications for a long period of time, which is made somewhat easier by providing in fixed dose combination tablets, but still means a long course of treatment for people taking drug-sensitive TB treatment. So we've seen the challenges are it's many tablets. It can be a challenge for someone who's ill to take. The treatment is long, 6 months, requiring excellent daily adherence to prevent resistance. The potential for toxicity, so side effects, increases the longer you take a medication, and it is a very long course of treatment. There are many interactions between standard TB treatment drugs and other medications that people commonly take, particularly medications used to treat HIV, but also other common medications like blood thinners and anti-seizure medications. And then we also need to think about the challenges of treating TB and HIV together, in particular immune reconstitution inflammatory syndrome, which can emerge when starting TB treatment in someone living with HIV. So one of the more recent efforts to shorten or simplify TB treatment, this is a study that was published a couple of years ago that looked at reducing the number of drugs needed to treat a course of TB. And this group looked at dropping the ethambutol once isoniazid sensitivity was confirmed. So the goal of using the drug ethambutol in the combination 4-drug regimen is really to protect against emerging resistance to rifampin if there is any isoniazid resistance present. So they look to see whether, if you confirm that isoniazid sensitivity is present, can you just drop ethambutol so you only have 3 drugs in the initial intensive phase? And they found that dropping the ethambutol was in fact non-inferior, so functionally equivalent, equally good outcomes. So this is sort of an effort to shorten, simplify the amount of treatment given. The next simplification or shortening approach that we'll discuss is attempts to shorten treatment from that 6-month regimen down to shorter, 4 months, 2 months. And one approach was to explore the use of the class of drugs called fluoroquinolones. These were attractive because they have known early bactericidal activity, So they can kill a lot of bacteria early on and really knock down that bacterial load. And the hope was that by including a fluoroquinolone in the initial intensive regimen, that the total length of treatment could be shortened since more TB drug killing would happen earlier. There were 3 critical clinical trials that were done in 2014, all of which replaced, all of which used a fluoroquinolone in the intensive regimen. And unfortunately, these trials all showed that a 4-month fluoroquinolone containing regimen were none of them were non-inferior to standard 6 months. That's a little bit of a double negative. Basically, none of them were improved. Certainly none of them were improved, and all of them were inferior to a standard 6-month regimen. The one subgroup that was considered was that maybe people with non-cavitary TB disease still did as well with a 4-month regimen. But because of these 3 landmark trials, WHO in 2017 issued guidance saying that a 4-month fluoroquinolone containing regimen should not be used to treat drug-sensitive pulmonary TB. And that's where things stood. We were stuck with 6 months as the minimum duration of TB treatment until 2021, when another study looked at not just including a fluoroquinolone in the treatment shortening regimen, but also changing rifampin for rifapentine, which is a related drug. And so this project, this clinical trial compared 3 regimens. It looked at the standard 6-month regimen, and it looked at 2 different 4-month regimens, one that used rifampin and moxifloxacin, and one that used rifapentine only as the change. So replaced rifampin with rifapentine, and one that used rifapentine and moxifloxacin, fluoroquinolone. And this trial looked at the endpoint of TB-free survival at 12 months. It was, again, a non-inferiority trial that compared these 3 groups. And importantly, people living with HIV were included in this study. And what they found was that the control, the 6-month standard treatment, was equivalent to the rifapentine and moxifloxacin shortened regimen, so fluoroquinolone containing shortened regimen, but rifapentine alone without moxifloxacin was inferior. So based on this study, WHO issued new guidelines in 2022 saying that people aged 12 years or older with, again, drug-sensitive pulmonary TB may receive a 4-month, so a much shorter regimen of isoniazid, rifapentine, moxifloxacin, and pyrazinamide. And so this is really exciting. This is the first time in 50-odd years of TB treatment that we have moved the needle on shortening TB treatment. But there's still some implementation challenges, even with this new shorter regimen. It's really only appropriate to use moxifloxacin or fluoroquinolone where there's a known low prevalence of fluoroquinolone resistance. And it's hard to test this on an individual patient basis because drug sensitivity testing for TB with standard testing really only checks for rifampicin resistance. So it's hard to assess on an individual level whether the TB an individual has is fluoroquinolone susceptible. With this 4-month regimen, there's still an issue of pill burden. There are no fixed dose combinations of these 4 medications for this regimen yet, although the hope is that as this regimen becomes more commonly introduced, that will provide a market for fixed dose combinations. There is a national and global shortage of rifapentine, and so that makes implementing this month challenging. We also have very limited data from clinical trials of the use of this 4-month regimen in people who are pregnant and in older people over the age of 65, because these people were not represented in the clinical trials. And we know that fluoroquinolones have different effects in people who are older, many more interactions, complications, side effects with drugs people take. So the story is not yet finished on this 4-drug regimen. But it's very encouraging to see that countries are slowly adopting the 4-month regimen into national guidelines. And the more we learn with implementation, the more we'll be able to use it. The next big step with shortening TB treatment was the 8-week treatment regimen investigated in the Truncate TB study, which found in a study that did not include people living with HIV that an 8-week regimen containing bedaquiline and linezolid was non-inferior to the standard 6-month regimen. So this is really exciting as a potential 8 weeks or 2-month regimen, having the progress that we made already to see that we may be able to shorten treatment. Now, again, this study is probably not the end of the story. There were emerging resistances that were noted in the trial. These drugs, bedaquiline and linezolid, are really limited in access and availability. Bedaquiline had previously only been used for drug-resistant TB. So many challenges before moving this into a standard treatment program, but still a very exciting proof of concept that we may be able to further shorten treatment. The last treatment shortening study that I want to discuss is one that was unfortunately not successful. So this is another 8-week. This was a 4-month, another 4-month treatment regimen that was proposed using the regimen BPA-MZ, which is bedaquiline, protomidate, moxifloxacin, and pyrazinamide. And the study was done both in drug-sensitive, people drug-sensitive and drug-resistant TB. We'll just talk about the drug-sensitive TB, comparing a 4-month regimen to the standard 6-month regimen. And unfortunately, although from the primary outcome, so 8-week culture negative, the shorter regimen was in fact superior at the 52-week, at the 1-year endpoint. The shorter regimen did not meet non-inferiority criteria. And also importantly, there was about a 10% discontinuation rate of the investigational short regimen due to toxicities and AEs. So this is not a regimen that will be moving forward in part because it was so poorly tolerated. In terms of thinking about challenges for treating TB, specifically in people living with HIV, there are a couple key barriers. So rifampin causes a lot of drug interactions with many antiretroviral medications. The former first-line antiretroviral regimen had no interactions with TB treatment, which was very convenient for treating them together, but this is no longer the first line. And the standard first-line ART in most of the world is TLD, tenofovir, lamivudine, and dolutegravir. And because of this rifampin interaction, dolutegravir needs to be dosed twice a day instead of once a day, outside of a fixed dose combination. Most second-line ART can't be given with TB treatment with rifampin. And some of the renal sparing medications used mostly in high-income settings can't be given with RIF. So thinking about goals for new drug-sensitive TB regimens, these are goals that would be regimens combining some of the new products that Dr. Parrish talked about. But the goalposts that we're aiming for is a regimen that does not interact with first-line ART, that the trials include PK studies to ensure that ART remains effective. The goal would be to have a shorter TB treatment regimen, which would also have less opportunity for drug interaction. And one thing that's now being actively investigated is consideration of whether a universal short regimen is possible. Universal meaning it treats both drug-sensitive and drug-resistant TB. So there are current ongoing trials that have been initiated in the PAN-TB consortium using these combination regimens, and we should have some results in the semi-near future about whether these are effective at shortening treatment regimens and can be used regardless of the drug resistance. So very quickly, I want to mention the kind of key tension with starting TB treatment in people living with HIV. People who have HIV and have immune suppression and who are not taking ART, we need to balance the benefits of starting ART early, and benefits meaning we get people on treatment effectively, we get viral load suppressed, allow immune systems to come back, and the immune system is really necessary to fight TB, with the challenges of starting ART early in someone who has TB, which includes drug interactions with TB treatment, drug toxicities, pill burden if you're starting ART and TB treatment together, and the risk of immune reconstitution syndrome. So there were 3 major studies in the late 2010s or early 2010s that investigated this question of when to start antiretroviral therapy in people with HIV and TB. So everyone started TB treatment immediately, and then people were randomized to either starting ART early within 2 weeks or late within 8 weeks. And all 3 studies in different settings found a benefit in starting ART early. So even though there may have been some increased iris, the mortality benefit was high and highest in people with the lowest CD4 counts. So because of that, WHO issued a guideline saying we should start TB treatment immediately for everyone, and ART within 2 weeks for people with a CD4 less than 50. And that guideline was then modified in 2021 to recognize that any delay in starting ART is, as an implementation issue, a challenge. And so delaying in order to optimize, or because there's no benefit in starting ART early in people with a CD4 over 50, people had been delaying starting ART and then sort of delaying indefinitely. So in recognition of the fact that operationally, it's much better to start people on their TB treatment and their ART in very close concert, both TB guidelines and HIV guidelines recommend starting ART within 2 weeks, regardless of CD4 count for people with HIV and TB. There's many other considerations with treating TB and HIV together. Some evidence that using higher doses of rifampin might be more effective. There have been studies showing that people with advanced HIV disease with CD4 less than 100 benefit from getting empiric prednisone. That was the PREDART trial. And there's ongoing studies looking at ways to optimize, particularly for people with advanced HIV disease, treatment to reduce mortality from TB and HIV. There's still a lot of questions for what lies ahead in the future for drug-sensitive TB and TB HIV. So we've seen that 4-month treatment is possible. Can we go even shorter? Is there a role for host-directed therapies to be given along with TB treatment to improve the human body response to TB? We've seen in the rations trial that food prevents TB. Giving people adequate nutrition prevents TB from reactivating. Is there a role for that nutritional supplementation within treatment? And what is the optimal type of support provided during treatment to improve treatment outcomes? Should we be monitoring drug levels during treatment to optimize outcomes? Any other treatment biomarkers that we could be following to help improve outcomes? And then finally, thinking about whether TB treatment can keep up with ART drug development. It's been in very exciting news. We now have long-acting ART treatment that can be given every few months. There's now a long-acting PrEP agent that can be given as an injectable once every 6 months. And these are fantastic advances for HIV that really reduce treatment and prevention burden for patients. But what are the effects of these long-acting medications being given with TB medications? Are they still as effective, or do the TB medications reduce their efficacy and sort of attenuate some of that benefit we have? Do we have the potential for long-acting TB treatment to be given as these kinds of injectables? So I'm going to stop there. I'll take any questions in the chat, and I want to thank all of my collaborators and mentors and teammates who have brought me to this point, and acknowledge the CTRAC and its component organizations. Thank you.